Good morning, everyone. Today's we have many exciting live case transmissions from the several hospitals, and so we're gonna start with first live cases. Before that, I really, happy to have Michael Lee here as a co-moderator, and panelists Dr. Myeong-Ki, Dr. Seung-Ho, Dr. Kang, Kim Won-Jang, Lee Junghoon, Dr. Yoshihiro Noji, Dr. Park Jae-Hyoung, and Seung-Jung. Come on, okay. Thank you for joining with us. All right, ready for first cases, Asan Medical Center? Okay, Dr. Park, can you hear me?
Okay, can you hear us?
All right, so we can clearly hear you, and so would you introduce?
Thank you for joining the Complex PCI 2023 live case demonstration. And at this year, we prepared a lot of interesting cases, mainly the complex PCI, the left main disease, and the severe calcified region, and bifurcation and CTO region. So, and I introduced my team. I'm D.W. Park from Asan Medical Center, and Yono Choi, he is our senior fellow, and the Jin-Seok, and he's our senior cancer lab staff. And so we're gonna start the patient presentation, and Dr. Chen will present.
Yes, thanks for introduction. Let me start presentation. This patient is a 74-year-old male, and he has referred for effort chest pain, and he has been treated with hypertension and dyslipidemia, and he has no past medical history. Next. He had hypertension and hyperlipidemia, and the clinical presentation is just stable angina. Next. Next, please. EKG shows a sinus rhythm and frequent BPC. And next. This is a chest X-ray. Chest X-ray shows no cardiomegaly and there's no abnormal findings on both lung. Next. Echocardiography findings shows normal average systolic function and a kinase of posterior wall. Next. This is a baseline coronary angiography. Right coronary angiogram shows diffuse stenosis at proximal to mid ICA. Next. We can see the significant stenosis at distal left main and proximal mid LAD. And there's a previous one. Yeah. There's a significant stenosis at distal circumflex with collateral flow, and there are some stenosis at circumflex os. Next. This is spider view. We can see the trifurcation and the distal main stenosis with RI branch. Next. We have fixed the ICU region with Giant's sky point 2 days ago. Next. So today's target region is the distal main and proximal mid LAD region, and distal circumflex total collateral region. Yes.
Okay, could you show the first slide? So first, I'm gonna summarize this patient. Is a 74-year-old male as presented with effort-related chest pain. The angiography showed the triple vessel disease and the RCA region and the cell kind of LAD and distal bifurcation region. And as shown in the last slide, we already picked up prox RCA region, put the the stent well, and the Giants scoring point 3.548. FFR was compromised proximal RCA, and the treat well. Today we're gonna treat the left coronary, and could you show us the first coronary angio? The today? Okay. So, and looking at the first view, this is area coral view, seems to be like not simple. And distal sock is thoroughly occluded. And there seems like some collateral flow from LAD and the RCA. And overall, the territory is not so small. And the next one. Here, and the distal sock is thoroughly occluded, and approaching angle is not to be easy, and there is some side branch in the outlet, and so distal left main and proximal LAD, and there is a significant calcified region. And the next one. This is the epicranial view and the areocranial view. We can see the region was extended from the shaft left main to the middle LAD part. Next one. So this is the epicranial view, and we can see the region seems to be extended to the middle LAD, and the calcium is seems like very severe. And before injection, we can see the easily check the status of calcium. There was a severe calcified region. And the next one. And this is very interesting imaging in the spiral view. We can see the trifurcation, and by angiographically, and the sock ostium and the ramus branch ostium seems to be okay. And but this absolutely the distal left main was narrowed, and by definition seems to be 110 or 11. The one is that require the imaging evaluation. So, and we discussed and already, and I would like to hear his opinion from the panel and the audience.
Good, great. Definitely, the disease involved the main and three vessel disease, right? Michael, so, first opinion. So from the United States, how would you treat a 74-year-old gentleman and the main and triple vessel disease?
Right.
Would you?
So first and foremost would be calculating the syntax score. I don't think it's going to be above 33, so I think you should be okay. So there's probably going to be no difference in mortality. From a tactical standpoint, I'd like to see IVUS if the ostium of the circumflex is involved, because if the ostium is not severely involved, then it becomes much more simpler to do. Secondly, the question is, when do you address a CTO or versus address the LAD first? So again, all depends on IVUS of the circumflex. If there's no disease, take care of the left main, address the LAD, probably needs plaque modification with the rotation atherectomy. Once you secure the left main, then you can go after the CTO of the circumflex when the patient's more stabilized.
You agree with in terms of anyway the stent procedure, right? PCI, right?
I think it's very reasonable, especially the patient's age. There's no difference in mortality. I think it's fair to say 5 years, 10 years, no difference in mortality. Maybe a higher risk of TVR, but no difference in mortality. So it's patient's preference, patient autonomy.
Okay, lots of changes even in the U.S. doctors
mean,
talk about the PCI rather than the bypass surgery. So great. Any comment? Any discussion point from the surgery versus PCI or technical aspect in detail? Dr. Kang, Seung, any idea?
Yeah.
Suggestion?
And in case of the left main bifurcation and the distal stenosis is combined, so as Michael said, at this point, do we have to focus on the bifurcation first, or do we have to treat the distal region first? Is another discussion point.
Okay, so Dr. Baga, how would you do that?
Yes. So, and as you mentioned, some distal sock seems like not small size, and could you show us the angel? So we try to first people treating the left main disease, we try to is pass the wire in the sock part, and after the insert and the microcaster, and this is the injection by the microcaster. You can see there is a not clear the stump. Also there is some side branch outlet. This is not simple region, and take time to pass the wire. Initially we try to fill the XT wire, and as shown, and this view is wire is passed out in the small the OM branches. Take time more than 10 minutes. I'm slightly frustrated over here, so I have changed to another wire. The XT. This is the Gaia second and the CTO wire, and then this part is I got some micro band, and the direction is inner side, and this is the Gaia second, and next
wire,
one,
right?
yes, CTO wire. So, and fortunately at this moment, and you can see here, and take time. And I try to spend more than 20 minutes to pass the suck region, and the suck region seems to be not small. And then successfully wire was passed over here. This is the Gaia, the second wire. Next one.
Great.
Next one. Okay, here, and the wire was past the distal suck region, and next one. So, and the wire was successfully passed, and here we put the more advanced in the microcaster, the distal suck part, and then we change the additional household wire, and next one. And here, and we do 2.5 balloon the dilation using the compliant balloon, and the compliant balloon expanded well. As you can see, this absolutely distal suck region is not small region. So, and over here, and we try to evaluate the whole segment, and before balloon implantation of the prox-LED, IVUS does not pass. We do pre-dilation using 2.5 balloon is prox-LED, and at first we already treat the distal suck. And could you show us the IVUS imaging suck region first? So, and I would like to show us the baseline angio first. The circle 먼저 본 다음에. So as you can see, and we is after balloon dilation. Yes. Okay, here. So, and after wire passage and balloon dilation, as you can see, you remember at the initial view, and the prox suck is looks like accordion. Initial view looks okay. After wire passage, and there is some the morphology change. At this moment, imaging is very important to decide that there was a true region or accordion, and so we evaluated IVUS and the suck. Could you show us the IVUS?
5천 더 드려.
네.
So, and this is distal suck, and the size is not so small, at least 3.0, and the distal suck.
들어가기 전에 ACT 한번 체크하게 해주시고요.
조금만 더 봐. Okay, here, and the plaque was extended in the distal part, and you can see the very severe calcium. Also, there was some dissection, and on the basis of IVUS, we require at least more than 3.0, the stand sizing, and then you can see the plaque. Here is you can see the dissection.
After balloon dilation.
Yeah, after balloon.
Big vessel is more than
Big vessel, or here is the calcified part. Also in distal suck was calcified region. So, and the region was extended approximately length is 26, and then we're gonna move to the quickly and the prox suck. Prox suck로 가야지. So, and you can see the prox suck is there is the plaque, but however, and the lumen was maintenance at least more than 5 or 6. That shows that part is not true region. That part is accordion. Also here we can find and the suck ostium over here. There is some calcium, but the lumen was maintained. So we decided to, at this moment, just to treat the distal suck and the spot stenting, and then evaluation LAD. Would you like to put just the stent crossover from the mid LAD to the left main, just to leave it alone, the suck ostium. So we put the 3.25 Giants 28, and then could you show us the final? Okay, here, next one. Final suck view. Okay, here. So we already put the suck region, and absolutely, the suck region is okay. And so in the IVC evaluation, the suck ostium is relatively okay. At this moment, we would like to check it up the prox LAD and the distal limb main, the IVC evaluation.
Big
So
vessel.
any further the question or comment?
Right.
Is how do you the panel is treat the suck ostium or any another option or any different option with cranial?
Any suggestion?
소리가 안 들린다. 선생님
So,
말씀하시고
Circumflex
여기 지금
ostium.
완전 블락됐어.
because there is the calcified region, so the lumen area is preserved. So it is a good choice for just leave alone and the cross over the stent.
그치? 이거 그지? 안 들어가지? 여기구나. 한번 내가 밟아볼게. 자, 그러면 본론을 더 줘봐.
물론 NC 3.25 나온 것도
3.25 나온 거 있고 아까 한 게 NC를 일단 3.25 NC 줘볼까?
Do you want to try IVUS for LAD?
귀가 안 들려. 선생님 말씀하셔. 아예 하나도 안 들려. 이거 혹시 빠졌는지 한번 봐보지. 선생님 앞에 말씀드리고 저 하나도 못 듣는. 연우 너 들려?
저도 지금
Can you hear me?
변호사 안
Dr. Ba?
이거 귀. 안 들려.
All right. So anyway, for the main
Dr. Park cannot
PCI
hear.
concerns, we
checked
very strongly recommended IVUS guided.
Yes,
Actually,
absolutely.
with some data, but for particular the main PCI, some improved procedural success rate and even in the survival rate, something. Particular circumflex OCR part, we got really detailed information, right? Some superficial calcium, some narrowing of bioangiographic findings, however, keep the minimal lumen area, something like that. It's a very important, information.
Is it
from
dictate
IVUS.
strategy, single stent versus
right.
two-stent approach?
Absolutely. Two stent or just a single stent crossover, we can separate that.
This is NC balloon, and the IVUS does not pass, and we try to pre-dilation. Deplete. This is 3.25. So, and for evaluation, 6, 8, 10,
6, 8, 10,
3.11,
12.
3.25
Okay, deplete. So, 6, 8, 10, 12.
6, 8, 10, 12.
3.25
Okay, deplete. We now using the 8 French guiding caster. So, go. 7인가?
7입니다.
7
10,
French.
12,
12, 14, 16.
14, 16.
3.3
Okay, deplete. 16, 18.
16, 18.
Okay, deplete. So I'm gonna check it up angio and then the evaluation I will see so and it's in the renovate complex PCI in the published New England Journal of Medicine. Also, at this year, the ESC meeting 3 consecutive imaging-based trial, Illumin 4 and our Octopus trial, as well as October trial is published in the major article. And this year, I think it's a booming year of the imaging-guided PCI. As I mentioned, the imaging-guided PCI is very helpful for the experienced interventional cardiologists, more helpful to learning curve period interventional cardiologists. The main purpose of the imaging-based PCI and can reduce the expertise gap between the early career and the senior career, the interventional cardiologist. So at here, and I would like to advance the IVUS. 좀 더 할게. 오케이, here. 여기도 타이트하네. 다 있네. 오케이, go. So,
Yeah, perfect.
so this is a really mid distal LED part. 진동대 조금 들려? And here and the 3.0 and plug over here lumen is
All right.
So far, the arc of calcium seems no bigger than 180 degrees, which is helpful. Maybe a little bit more there, maybe approaching 270, but they're about 180.
so on the basis of IVUS, we can imagine over this part and at least the 3.0 stenosis required. This is 3.5 for at least 4.0. Here. And you can see some dissection.
Basically diffused disease, right?
Right.
We have to.
Here is calcified region, and this is the most toughest part. And I was initially does not pass, and the calcified part was breakdown by NC balloon.
Great.
Good. Here and we can see, and the Ramos branch wiring coming is also seems to be good, and the sarcoosteum is by this angle is widely open. The calcium was extended to the distal main over here.
Did you dilate the distal limb main? Sharp?
Yes,
All
yeah,
right,
already
good.
I dilated.
All right, still.
3.5. So, and this is the mid sharp. So, on the basis of IVUS, I think some proximal landing zone and shaft left main would be okay. So, and I did already perform the NC balloon 3.25, and in my view, and calcium was blacked out. At this moment, it's a calcified region. One of the interesting topic in the interventional cardiology is a lot of region modification modality was suggested on the basis of the imaging finding, on the basis of IVUS, on the basis of OCT, and according to different morphology of the calcified region, diverse region preparation was suggested, including intravascular resorption or laser or orbital atherectomy and loral ablation, or the scoring balloon, and NC balloon dilation. So how do you think about which region preparation would be required this patient? So in South Korea, we didn't have experience like laser or orbital atherectomy. And Michael, and you have an expert in this part. And do you think which region preparation is required for this patient?
So you balloon the calcified lesion, you IVUSed it, and we saw a calcium fracture. Basically, you achieved what IVL would achieve. So I think it's very helpful. Now, before you set the left main, it would be nice to see how a 3.5 NC balloon profiles. I don't think you necessarily need to do atherectomy right now because I think you got a good calcium fracture. But let's see how a 3.5 performs, just to see if it completely profiles or not.
Dr. Bang, would you take a picture after the NC balloon inflation? So we're gonna see what's happened by
Ready?
nitrous as well.
Okay, so one more. 이 가이딩을 좀 더 놓고 잠깐만요. 왼쪽 귀 좀 봐주세요. 자, 테스트. Okay, enjoy.
Picture first.
Okay.
So what would you do that in the distal landing? So
Yes,
stand
distal
where
landing
the-
absolutely should cross over the diagonal branch on the basis of IVUS, and the region was, just distal part of the diagonal branch lumen areas less than 2.0. So we require, my intention is to try to the two-stand crossover from the mid LAD to the distal left main part on the basis of IVUS, and the first insert 3.0 is for length is 28. Yes, 28 is okay. Okay.
basically diffuse calcified region, right?
Absolutely.
So
absolutely.
Dr. Michael, what do you think is by our findings? Do you want to start with the rotoablation, something like for particular cases? Start with the rotoablator.
Now my paradigm is shift. I now use intravascular lithotripsy because it's just so easy to use. You don't have to have a specialty wire, but it's $4,500 per balloon. It's very expensive. So
Intravascularly subthrushic
All right.
coaster,
Correct.
right?
Technically, all right,
It's just simple.
very simple.
no distal embolization, no hemodynamic compromise, no wasted time exchanging back and forth. And
Yeah,
the
so
beauty
we
is-
just use a non-compliant balloon. This is a very cheap procedure.
Right.
but
So
you
okay,
accomplish the
that's
same
actually,
thing. You crack
that's
it,
a,
fracture
yeah,
the plaque.
that's a point.
세개 들어가서.
In fact, every calcified
조금만
region, we want to
세게.
try the
됐어요?
NC balloon first. Almost 28 atmosphere, 30 atmosphere, high pressure
test.
can make a breakdown in any calcified region. Save the money, those we cannot do. We don't want to do the rotoablation. Something
The
like
one
Okay,
potential
the
disadvantage is that if you go high pressure and you dissect, then rotational atherectomy may not be a viable option at that time.
10 to 14.
16.
16.
practical
This is
point of view, in
3.0.
almost all
Okay.
cases, we can break down. So very small
Yes.
numbers, and so
10, 12, 14, 16. This is a
10, 14,
3.0,
16.
the Giants sky point. Okay, deplete. So, and the Michael, is it such like a severe calcified region? Do you have any preference for some different the specific type of drug-eluting stent is among the contemporary drug-eluting stent?
I think all the top three companies, Abbott, Boston, Medtronic, I think they're all comparable. I think there's no study to distinguish one stent is superior to another. So I think you have the option of Xience or Medtronic, Synergy.
약간 길어도 될 것 같아. 33 주세요.
any
네.
any different any difference according to the any different regulating stent?
I think if there are differences, it's going to be so small, maybe 1 or 2%. So again, going back to the number needed to treat, it's going to be so large. So I think I feel very comfortable. If your lab is dedicated Abbott, I feel no problems using Xience. If I dedicated Boston, I feel no problems using Synergy.
So, in the Michael, do you have any experience of the orbital atherectomy? Is the orbital atherectomy Eclipse trial is already enrolled 2,000 patients, will be presented, I guess, the next year. That would be provided some important evidence about orbital atherectomies. And many American doctors that have experienced the orbital atherectomy, there is a much easy to use and intuitive rather than rotablation or atherectomy. And do you have experience about the orbital atherectomy?
Yes. Prior to Orbital, I was using Rota, but once Orbital became available in 2013, I almost exclusively switched over my practice to Orbital because it's so much more versatile. Let's say you have a 3 millimeter diameter vessel. You start with a 125, let's say with Rotablator, but then you have to go to 1.5. But with Orbital, it's the same crown, so that 125 crown, by just going from low speed to high speed, you get more atherectomy. It's much more easier to use. The wire is easier because you also have orbitation of the burr. You have less dystomalization and hemodynamic compromise.
있죠? Okay, this is 4.0. Okay, test. 자, 이게 모습까지 나올 필요가 없지. 잠깐만. 자, we're gonna check it out. The stand was overlap. It's not yet overlap. Okay. overlap 됐지? Okay, test.
28.
Yes, this is 30. Yeah, 4.0. Okay, 한번 찍어보자.
4.0. Right.
Okay, this okay, go. 4.0 and the giant stand. Okay, here deplete. Okay, and then remove. Okay, slightly remove gently, and then here, and we will check it up the epicranial and spiral view, and is some different change of the ostium of the suck as well as ramus. Okay. Joe? Yeah. Good.
Great.
And
Perfect.
spiral view.
Perfect.
여기 좀 들어오세요.
So, what would you do that in the next stage?
자, 여기 잘 보인다.
Circumflex ostium.
Okay, good.
Good,
So, and
perfect.
this is a spiral view. Even though we just stand crossover without the, several thinking, it seems to be good. And the ramus ostium is perfectly not compromised. The suck ostium is not compromised. The last step, we just do final NC balloon dilation using the 3.25 and distal part and the mid-elite part 4.0. That would be the last step. And this is, I think, some typical, case of the, even though the angiographically looks complex, we can make it simple. And if you decide PCI strategy, and you can go straight forward, you can make it simple, absolutely.
Okay, would you show us again the spiral view, Dr.
Spiral
Park?
view? Yes.
All right, just to point out, circumflex ostial part, actually I was finding some, encircling calcium, some transition to the polygonal confluence anyway, there is some narrowing. However, angiographically perfect. The reason why there are very steep angle, that is another, very important issues. And the angle prevent in terms of a corona shift in, after the main branch stand. And another point is, Dr. Michael, you mentioned about the high syntax score. If you look at the main itself, only main disease,
라무스는 빼도 되겠다.
the other concomitant epicardial artery disease is related with high syntax score. Even in the Excel study, you know that the data up to the 45, less than 45, it would be okay. The meaning is not too much related, any clinical outcomes in terms of a syntax score. I don't believe too much about that. Once in any complex region subset, less than 45 syntax score, meaning is almost all the case of the main disease, we can try PCI also, right?
Also,
You know
just
that?
anatomically, these are very feasible. There's not a lot of tortuosity. There's not a lot of angulation. You have a big, wide LAD circumflex, which is very
10, 12,
Right.
tends good outcomes.
Very conceptually, we really afraid about main high syntax score. However, if you look at in detail, you can fix up the the other epicardial artery, very simple lesion subset. Why not? We're gonna do
Also, the CTO was relatively short. We're not talking long 30-millimeter CTOs, which increases the complexity.
We can send the patient to surgery for. Right.
No, this is great. This is why people go PCI of the left main. This patient will go maybe home tomorrow. There's no recovery time in the ICU with chest tubes and Swan-Gan catheters and Foley catheters. This is
All
great.
right, Dr. Bang, we need a final angio first,
Yes,
and we're gonna move.
okay, fine, yes. And the final angel, 한번 이거 찍어보고 the prox editor 해야 돼. Angel ready? Okay, it's good.
All right, I think it's
Spiral view.
perfect. And spider view, cool.
입에도 보이나 보자. Angel ready? Okay.
There's some narrowings, right?
Yes, and here
However,
part, and with the spider view over here.
Dr. Perk, would you do FFR or just image again of the circumflex?
Yeah, yes, and
No,
initially
we don't
checked
need
up
that.
the
we don't need to. We know that, but they got to be
So
FFR.
yes, after additional high pressure balloon in the left main, and we will check it up the ostium status. If required, and there is a significant narrowing was suspected, we will do FFR evaluation the ostium.
Okay,
And
good.
okay.
Dr. Really, good cases and good informative cases.
Thank you.
And so we're gonna move. Second case, Dr. Ahn is there.
4점 얼마 되겠어?
Jung-Min Ahn. Okay, can you hear me?
I can hear you.
All
Good morning,
right.
Dr. Bob.
All right.
So-
Would you introduce your cases?
Yes, we also are preparing another very interesting case. The Gino Lee, our senior fellow, will introduce the patient history. Could you please?
Yeah, thank you for introduction. I'm Jinori from Asan Medical Center. Today, our patient is a 53 years old male patient with repro chest pain. He had been treated with hypertension and dyslipidemia. He had no past medical history associated coronary artery disease. Next. He had the 3 risk factors, which are the hypertension, hyperlipidemia, and current smoking with 27 PEG years. And clinical presentation is stable angina and CCS functional class 2. Next. Electrocardiogram showed basically normal sinus rhythm and no ST change. Next. In chest radiograph, there's no cardiomegaly and no pulmonary edema. Next. And echocardiography showed the normal echocardiography with preserved LV function. And next. And we checked the coronary angiogram, this RCH view, and 2 intermediate lesions as PDA and PL branch. Next. So we checked the FFR to each vessel, and the PDA showed the FFR value is 0.77, and the PL branch was 0.82. Next. There is a left coronary angiogram showed in the caudal view, there's a diffuse disease as proximal to circum disease, and you can show the left main shaft very severe stenosis. And epicranial view with LAD showed the significant stenosis. Next. In the spiral view, you can see the severe stenosis on left main and Rams branch. Next. So 2 days ago, we treated the PDA branch with the drug-eluting stent. Next. So we set the target lesion as the left main bifurcation and ramus and LAD portion, and so we planned the device with the IBUS.
Okay, could you show us the angio? Yeah. This is today's epicaudal view. You can see the very tight calcified left main stenosis and some diffuse disease on circumflex. Also very diffuse disease LAD and spider view, please. This is previous next LAD. Yeah.
Cranial.
Okay, this is cranial view. So
Very
there
tight.
are 2
Tight
very tight
stenosis, right.
left main and some lesion in the mid LAD. Next. So this is spider view, the big ramus or the high diagonal branch, some disease in the proximal portion, and this are left main involving the left main bifurcation. So could you any comment on patient history and coronary angiogram? Could you discuss how to treat this patient?
Basically, Korean doctors actually are familiar with the main PCI. Michael, would you do surgery?
It's a heart team approach. I would offer, but I think this is technically feasible. I think the ostium of the circumflex is not diseased, so I think you're not going to have to do a 2-stent approach to the left circumflex, but I would IVUS it. If it's not severely diseased, you could do 1 stent crossover. The circumflex, the ramus is a large vessel.
Yeah.
So the question is, do you do a 2-stent approach for that? I'd want to IVUS, first of all, the circumflex. But with respect to imaging, I also want to see how calcified the left vein is, because if it's calcified, I think it does affect your management. The question is whether you should do plaque modification or not. But IVUS is important for the circumflex.
Great. So, Dr. Ahn, actually your strategy is a generalized concept in the United States?
I can't
You are
generalize.
Korean.
I am Korean. I wouldn't say I would generalize it to other U.S. physicians. It's based upon coming to your conference, seeing what other experts do. But generally speaking, I trained under the master, so I follow your lead.
Anyway, for particular these cases in general, physicians, the other, they got almost the same concept with you?
95% of U.S. cardiologists would send this 53-year-old male to surgical revascularization.
Right. Then, still, long way to go. Also, Dr. Ahn, what would you do there?
So yes, I agree with Michael's opinion. So definitely we have to see the inside of coronary using the IVUS. Could you show us the LAD pullback? We insert the wire in 3 wires here like this already, and we evaluated the IVUS from the LAD. Please run, please. So this is the proximal portion of LAD, some tight stenosis. Vessel size is 3.0 almost. The huge plaque, so looks like soft plaque.
Okay.
And this is the high diagonal branch, looks like Ramus. This is the circumflex. It's coming from the 11 o'clock. Here is this left main, very tight, some
Very
superficial
tight stenosis,
calcification.
right?
The main size is more than 4.0. Could you show us the Ramus pullback, please? Here is Ramus.
This
Ramus
one?
vessel size is only high diagonal branch. Yes, it's only the 2.0, 2.5. Some disease, diffuse disease. Vessel size is only 2.0, 2.5.
2.5. No.
Here is the proximal. Vessel is getting bigger, but even though the 2.5, some diffuse disease, but not that critical. Here is a very proximal. Okay,
Fortunately,
you can see it.
anyway, very much a soft plaque, right?
Yeah,
Rather
right.
than we expected.
Could you show us the circumflex pullback? This is a circumflex pullback. So our interest is ostium of circumflex.
Big artery, right?
Yeah, big artery.
3.5.
3.5. Here is the circumflex ostium, but this left main. So based on the LAD circumflex pullback is not because of eccentric location of IVUS catheter. Circumflex ostium is not that evaluation is not good for circumflex pullback, but from the LAD, circumflex ostium is definitely widely open. So what is your plan? What is your comment after the IVUS evaluation?
Lung branch actually, big
LAD에서
one.
좀
In terms of, my kind of fraction, the jeopardy area is a not small one, right? And so I think we have to fix up that one. However, relative to, 5 diffuse disease, however, soft plaque. So,
LAD에서
what,
좀 보게
any
해주세요.
suggestion, Dr. Ho? Difficult situation, right?
Yeah. Of course, we can choose the 2 stent, but as you mentioned, that circumflex ostium is still preserved, and also the anatomical, when we consider anatomical
다시
complexity. So, how about the gentle? Nowadays, the DEB is for the ramus branch, and the stent for the LAD. It might be choice for, in my opinion.
Dr. Song, what do you say?
Actually, I agree with the 그래서 the predilation with drug-eluting balloon is a viable option for this case.
Drug-eluting balloon for lung spread. Dr. Noji, would you give us some?
Two stent is one option, and another one is one stent crossover, protect wire to rames and LCX, and because the calcification is not so severe and widely opened LCX, so as the doctor mentioned, that the DCB finalization is another option, I think.
So, Dr. Ahn, what did you do there?
Yeah, actually, initially, based on the angiogram, we wouldn't think, we even thought that the more complex procedure. But based on the IVUS finding, look at the diagonal branch ostium is very close to the circumflex. So there is not enough room for the crush something. So in addition, based on the IVUS, ramus Ramus, the big diagonal branch ostium is preserved. So I'd like to make this procedure more simpler. So just keep the wire to the high diagonal branch and then just a simple crossover. I'd like to do a simple crossover.
All right.
DEB would be a good option, but if there is some dissection occurred after DEB, then the procedure could be the more complex. So without DEB inflation for the diagonal branch, I just the simple crossover from the left main to prox LAD.
All right. So
Could you give me the?
What about the mid portion of LAD? It's some narrowing over there. Mid portion. Would you show?
I just want to focus on the left main first, and then
right.
reevaluate the FFR for the mid LAD.
Great.
FFR is lower than 0.75 something. Then I'd like to do one more stent.
All right. So you're gonna do main prox LAD and main stent,
Yeah, right.
What length? What length of stent?
So based on the IVUS stent length, lesion length is stent length would be 33. This is circumflex. Actually, with circumflex wire is not necessary.
Good.
I remove the wire.
You got a
circumflex. Test, please. Okay. This is a 35 high pressure balloon. 10, 12, 16. Deflation.
Good.
Ready? Okay.
Good. Perfect.
Diagonal flow is not compromised.
Actually, the mid-digital part is significant stenosis. So why don't you? Oh, okay, would you keep on nitro after the balloon?
Nitro, please.
Why not? I just want to make a big.
Stem, please. 3.5, 33.
35.
Dr. Park,
Yeah.
I want to ask you a question. What is your favorite left main stent? I know there's a lot of companies out there.
And it's three. In my opinion, I don't have any difference in terms of current regulating stent. All right. Main difference is just stent slot itself. I don't believe the difference in terms of a drug itself is nowadays, right? And so how much big, scaffold, power, something like that. And so sometimes, some tortuous vessels I would like to Medtronic, coil stand, something like that. However, the other many cases with any stand, right? I try.
Is size a limitation? For example, XL, Zions, you don't want to go more than 4. The others that you go maybe to 5 millimeters.
There's some limitation of size selections. However, listen, all the regulating stands can validate up to 4 or something like that. Right? 33,
6. Yes.
35.
8.
What's then?
This is Giants.
Giants. They like a giants.
Zions.
10, 12, 18. Deflation. There is no change in the EKG, so enlisted.
Dr. Ahn, is there any favorite stent that you like to use for the left main, or they're all consistent?
Excuse me.
Are they all the same, or what's your favorite left main stent?
No, definite. No, usually, no specific. No, my preference for the stand. The old stand looks fine.
I think it's good side branch wise, and even in the Lamus branch, team is 3-floor. Some hesitations, however, I think it's good.
And the circumflex looks fine.
Circumflex also is
3.5.
good.
For all high pressure balloon, short balloon, please. Yeah. 네.
At this point, would you consider rewiring the diagonal branch before you do high pressure inflation to the left main?
Yeah, I try because there is some haziness in the ostium of diagonal branch. So I try to rewire to the diagonal branch.
Just leave it alone. Right.
Keep it simple.
All right, right. That's the point. The remaining small ischemic burden, anyway, jeopardy area, is quite good enough. That is based on the ischemia study.
Right.
We will learn a lot from that one. And many clubs, bifurcation clubs, club, can make another wires. There's a balloon over there, and some make a, trouble with a stand over there. What's their, benefit for the patient?
Right.
Right. So we don't need another, rewiring for the diagonal branches. Right. That's the point. Just
네.
that's make it simple. Very complex region subset. However, we're gonna fix up main, target, make her almost perfect. Almost, that's our goal.
So this is 3.5 high pressure. 16.
Maybe visit to distal LED would be significant.
Deflation. Ten.
10,
12.
12,
Deflation. 20.
3.7.
Deflation. 4 high pressure balloon, short balloon, please. So this is for all high pressure balloon for left main. And then I will check the angiogram after the high pressure balloon stent optimization for left main part. Ten,
10,
12, 13, 14,
14,
16, 18,
18,
4.1.
deflation. Okay, 20, 24,
24,
deflation.
24 using the 4 millimeter, right?
Yeah.
Incident of
Final
final
balloon size is 4.4.
4.4. Big one.
So, nitro, please.
4.4.
Nitro, please. After nitro, I'd like to the angio. Okay. Ready?
Oh, perfect. Main,
Okay.
all right. Proxy LED main is perfect.
Yeah,
However,
right.
these two
There
distal
is a remaining mid LED stenosis. Ready? Okay.
I think
No
it's
branch
good.
no branch compromise. So, give me the IVUS.
Does it look like
Yeah.
there's about Timmy 2 flow in the ramus, just a little bit slower? Or the,
No, I don't.
Doesn't, okay. Not too much concern with that one.
Patient doesn't complain chest pain, EKG, no change in the EKG.
So, what would you do?
Yeah, here with the distal portion of.
Okay, expect of a main
Yeah.
minimal
this is
stent areas. You dilate to 4.4, almost more than 12 millimeter scale, right?
Yeah, right.
You
So I applied the 3.5 high pressure for this portion. The stent is very expanded. The movement is, I think, sufficient. Yeah, look at there is some room for the diagonal branch perfusion. So diagonal branch is not compromised. Here is the left main.
Big
Here is
stent
a very,
big stent area,
here is a
right?
very proximal portion of left main.
I think it's
Could you
perfect.
measure the left main?
Area, stent area.
area.
So could you?
Not that the tightest portion.
More than 12 millimeter square. You
Yeah, here is
Right.
here is your tightest portion. 9.9 distal left main, proximal
one.
left main,
okay, big.
and then I think left main stain is quite enough. So I'd like to measure the LAD FFR.
12. More than 12.
I'd like to
Long-term
pulled
outcome
out
is
the-
should be good, right?
pulled out the
You get
high diagonal
idea.
branch.
So the reason why I've guided the optimization, I think is very important issue factors for. So you do FFR
Yes.
should be positive, right? To angiographic too much, too tight stenosis. However,
Yeah,
all right, we have
sometimes,
to do
yeah.
that, right?
This is the FFR wire.
Dr. Ahn actually is FFR man, so he has to.
So
Zeroing first?
Yes.
Oh no.
zeroing here. Zeroing. Just a moment. Flushing. 네.
Okay.
Equalizing. Okay. Equalize the pressure.
Agree.
네.
Bifurcation.
You're almost ischemic, but you have the wire.
Yeah.
loaded. Yeah.
Perfect. Very interesting.
So ischemic at rest.
All right. Even
Resting is already
less than PDPA 0.71, right?
okay. Already ischemic.
All
So
right.
actually, we don't need the hyperemia.
Right.
Okay.
Great. Anyways, you clearly show us.
So distal stand, no gradient, but definitely mid LAD is
Same.
ischemic.
Absolute same, right?
Ischemia producing stenosis. So give me another stand.
Would you? Okay. Why not? Would you show
Ready?
some
Ready?
picture before the stand procedure? Picture first.
Ready?
Yeah. Okay. Once again.
Ready?
All right. Tight
주세요.
stenosis.
3O.
Okay, Dr. Ahn, it's
Yeah.
really good cases. We're gonna be back soon. The reason why it's another hospital, Severance Hospital, Dr. Hyoung,
Okay.
will wait for us. And so really good cases and crossover, very complex region, just a simple stent crossover, and some remaining ischemic burden would be okay. That is based on the data.
Impact on mortality.
Right? That's a point. All right. Okay, we'll be back soon. Dr. Hong, Severance Hospital. Can you hear me?
Yes.
All right,
Yes, of
great.
course.
Look, getting younger. All right, great. So, would you introduce cases for?
Yeah, this is my honor to be a part of the Complex PCI 2023. Before start the cases, I will introduce my team. Right side, Professor Lee, he's the junior interventional staff in our institute, who are I cherished in my heart. And actually, it is a good time to advertise to him the outside of it. During the last 2 years, he has the very big academic achievement. One of it in the JAMA and the BMJ, as you know, the impact factor of BMJ is more than 100, so he did it. And the last one is the second year interventional fellow. He's actually I teach it. It's very toughly. His skill is a high level. So if you want somebody want it, ask him. Okay, let me introduce our cases. Okay, Dr. Lee.
Good morning. This is our case. Our patient is 47-year-old male who came to our hospital due to the exertional chest discomfort. He has the medical history of dyslipidemia and he's a current smoker. So we have done the echo at the OPD. At the echo, there was a hypokinetic motion at the apex. The left ventricular systolic function was mildly reduced to about 48% of the ejection fraction. Next slide, please. So after he had admitted, we have the coronary angio. You can see the RCA, there was no significant stenosis. However, we could see the collaterals going to the LAD from the distal RCA. And you can see the caudal image, we could see the significant lesion at the proximal LAD, although it's kind of covered by the other vessels. Next slide, please. And you can see the cranial image. The right is the RAO cranial view. You can see the proximal significant stenosis at the LAD with the 2 diagonal branches coming out from it.
Diagnostic angiogram was actually done in the 2 weeks ago, and I will show the current status of the angiogram. Could you show us today's the angiogram? Not the slide. Photo. Oh, okay. This is the slide, the RAO caudal view. There is a very tightest narrowing, and around the lesion there is the 2 big side branch, first and the second diagonal branch. Oh. This is a spider view. Very tightest the LAD and the ostium of the first diagonal. And suspected that the also significant narrowing in the second diagonal. Next. This is the RAO cranial view. Look at the very tightest narrowing at the LAD and the significant narrowing in second diagonal branch. Another view. Next. This is the AP cranial view. In every live demonstration, the case for the PCI, complex PCI, they use the imaging. But actually, what is the real clinical practice? I'd like to show the real value of the imaging in this kind of the bifurcation region. Okay, this is a 3 region in the proximal LAD and the crowding of the big side branch vessel around in the first and the second diagonal branch. So what is our treatment plan? Of course, I will show the IVES finding. Before that, if you do fix it in this patient without the imaging, what is the treatment strategy? 3 stent or 2 stent or crossover it? What can we do?
Okay.
Without the IVES, the intravascular imaging?
Okay, we want to discuss Dr. Kang.
Yeah. First of all, the first diagonal branch is not so significant, and the second diagonal branch ostium is a little bit involved, but it looks not significant on in angiography. So, if possible, we put the 2 wire at the second diagonal and the LAD, and if without intravascular imaging, I will first choose the stent crossover to proximal to LAD.
Are you sure that the ostium of the first diagonal branch is preserved in the spider view?
Actually, I said not preserved. It is a little bit involved, but
Difficult
maybe
to say.
stent crossover will be possible.
By angiographic finding. Dr. Kim, Won-Jang, how would you do that?
Agree, Dr.
Right?
Kang. Yes, simple crossover is first.
Simple
And
crossover.
the provisional is something based on the imaging guide.
Patient is relatively young, a gentleman, 47-year male patient. And so, what did you do there? Michael?
Dr. Hyoung, what size guide catheter are you using? Just I want to give a
It's
reference.
a 7 French,
It's a 7 French.
XCB.
In my opinion, the diagonal branches are not larger than 2.5. So I don't think you need to do a two-stent approach. I would put wires in both the diagonal as well as the LAD, so 3 wires. Pre-dilate, see what happens to the diagonal branches. If there's no compromise, stent across. If there is compromise, balloon it, and then stent. But I don't think you need to do a two-stent approach because of the size of the diameter of the diags.
Okay, it's a very good comment. Is that actually the angiographic appearance of diagonal branch size is 2.5. It's an angiographic image, and let's match and validate what is the angiographic size of the vessel and the imaging based the size of the vessel. It's another educational point.
All right, great. However, in our lab, we didn't decide which strategy would be good for after obvious examinations. We're gonna do that, size-wise, something like that. Anyway, first diagonal branch is big, maybe between the 2 and 2.5. Ostial part by spider view, there are some disease, discrete narrowing, and so if we're gonna do, all right, just without, anyways, we need obvious, and so first diagonal branch keep some, very short stand for the ostial part, kind of upfront two stand, and another wire in the second, and I think the team 3 flow is enough for that one. So, okay.
I think it is a good comment. Therefore, imaging should be used in the bifurcation region for the determination of the treatment strategy. Therefore, class 1, more than a part. I think this imaging should be emphasized. Why we need what treatment strategy is better. Okay, for the time saving.
It's imaging.
Imaging is important. And when I wiring the LED, there is a flow compromise. I cannot wait for the more time for the patient chest pain. So the wiring, and
balloon force.
And this is I'd like to show what is the change between the pre-balloon and after balloon. I quickly, and therefore, and then IVC image and the LAD, and then for the flow maintenance, I did the balloon dilation at that.
Okay.
This is the angiographic finding. So, okay, show the pre-balloon IVC image, LAD. IVC 이미지론 해주십시오. Okay, this is the LAD, mid to distal. Actually, in here, the vessel size is around 3.0 or 3.2, and the more bigger, and there is a side branch vessel, and
almost 4, 1, 2, 3, 4, 4.
That is the pre-intervention. Okay, next. Balloon. And then
post dilation.
After the post dilation, balloon, and you see the distal vessel is more dilated. It means that the perfusion makes the more bigger size of vessel. So the what size of stent is the selection of it is important. So I need a more actual size.
Great.
This is 3 point more than almost 3.40. And you come to the second diagonal branch in here at the 5 o'clock. And now first diagonal is coming. In the epsilon from the LAD first, the bias is second diagonal ostium may be spared. And additionally, first diagonal branch is spared. I'd like to confirm it by the directly in the second diagonal branch.
Great.
This is vessel size is 2.7.
Is it
And so
diagonal branch?
Yes, the second diagonal branch.
Big one.
So
rather than we expected by angiographic
Mike Lee
findings.
said that there is maybe the territory is big, but the vessel angiographic appearance is the 2.5, and but in the IBS finding is different. IBS finding is vessel size more than 0.5. Anyhow, ostium is relatively spared.
Great.
Okay, next. First, this is the first diagonal.
Relatively small.
Yes, this is a difference.
Right.
It is the angiographic appearance totally different. So we can clearly measure the size of it. Okay, 계속 keep going.
Ostium?
Yes, that is the ostium of the first diagonal, very small. So stent it in that one. So, okay, I present the IBS information, whole thing. So it's time to decide what is the treatment strategy. Okay, for me, we achieve the imaging information. My plan is just simple crossover. And then there is some compromise of the vessel. At that time, I will try to fix it in the first or second diagram. That is my plan. Okay, any other comment or question?
Great. I really agree your way of thinking in terms of image guided, osteopath preserved, stent grafts, clear, make it simple, for the complex lesions subset. All right. So any comment on that?
This is just my personal experience alone. If you were to compromise that second diagonal branch, you have a parallel first diagonal branch near it. So in my experience, even if that second branch were to compromise, if you have a parallel vessel not too far away, I don't think they're going to have as much symptoms, ischemia at that time. If it was just one vessel supplying a huge territory of the diagonal branch, I think there's a higher chance the patient may have some hemodynamic compromise or ischemia, but that parallel branch is very nice to have. It's almost like a collateral to that territory.
Good comment.
Okay, great. Dr. Hong, proceed.
Okay.
Continue.
So based on any other comment, I will deploy the stent, select the stent. This is 3.5 Onyx 38, and deploy it in the nominal pressure, and then rewiring the side branch vessel, and then high pressure or anything based on the imaging finding. 조금만 기다려줘. 여기 에어컨 하고 나지.
38.
Yes.
3.5 Onyx, and whole stent can full cover the whole lesion. Distal part of LAD would be 3.0 something, right? So you want to do?
Yes.
So
Yes.
you choose a 3.5.
Actually,
and,
initial the IFC imaging is a 3.0. However, after the balloon dilation and LAD,
getting bigger.
yes, a little bit bigger, around 3.2.
Dr. Hong, you're back bleeding the TUI burst. Do you have air in the system, or what are you doing right now?
What? Yes, now I am doing the removal of air from the caster.
Okay.
Please give me a time.
Okay, take your time. My question that I asked earlier to the other operators, you chose an Onyx for this procedure. Do you have a favorite stent preference, and why did you pick an Onyx?
Actually, the other stent is a closed cell design. The Onyx stent is the open cell design. So this is the personal bias. The open cell design is more better for the next step manipulation. Faster. 가지. 노미널.
Nominal.
Nominal 12.
얼른. 노미널이야?
네, 12 nominal.
자, 인지하자고.
Ready?
Okay, let's check what is the status of the side branch vessel.
Good.
Okay.
Both branches good. Are good.
And then it's time to recannulate the both branch. And then post dilation at the LAD. 파일럿 주십시오.
Dr. Park, do you rewiring after stent for the two diagonal branch?
Right. All right. How can I say that? Operator discretions? Right. Anyway, first diagonal, second diagonals, nominal pressure, deployment stand, good patency. I want to do, high pressure balloon inflation first, and then, however, Dr. Hong may have some concerns after the high pressure inflation, some compromise that makes it more difficult to rewiring, something like that, right? So, however, either way, just, safety concern. However, I think it's good.
In terms of side branches, we see the same side branch, but have the different opinion because of we use the different definition about the side branch. But how about the current opinion? What is the definition of the meaningful side branch and the meaningful side branch stenosis? What do we have to consider the meaningful side branch at left main or any other bifurcation? Which side branch do we have to treat it?
Which side branches? Big one. This is the big one, right? Ischemic, big ones. And so we have to define which size is big. Michael, big vessel.
Generally 2.5.
2.5 something, right?
Reasonable, because when you start doing two-stent approach with 2.5,
right.
you're not going to get a good long-term outcome.
2.3, any 2.5, any I believe clinical, relevance concern is 2.5 is big vessel, right? Fair enough.
I don't think there's much data with two-stent approach with a 2.0 or a 2.25 stent.
Right.
주만하다.
Yeah. Over.
The meaning of the wiring is quite some easy. It means there is some patency.
Before high pressure.
Therefore, the wire is easily passed through the stent strut in the both branch. So therefore, it's time to the high pressure at the LAD. 이렇게 다 해보나요? 요거야? Okay. Anyhow, before that, let's do the IBIS. Which point should I have the attention? Angiographically appearance, and you see there is the indentation in the distal part of the stent. So I have to do that. Before that, what is the current status? 플러시 충분히 한 거지? 네.
Okay.
따라올까?
Dr. Hong, very much practical point of view. I would suggest in case of a long stent, nominal, pressure deployment during that one. So I would recommend it relatively long inflation durations, at least 20 seconds, 30 seconds. There are some, unbalanced, force to the distal part.
Yes, you
Vessel,
are correct.
vessel
But
size was a big one, right?
Yes, and the reason why, actually vessel size is, as I said, 3.2 or 3.3, but I deployed the 3.5. So if I make some, I don't like some operation or create a complication.
Right. Did a high pressure big balloon for the proximal part. However, distal.
Okay.
What about the distal?
Okay, let's check it
All right.
from the distal vessel부터.
Distal.
Okay, 천천히. Okay, this is a distal reference. And the transition is quite acceptable. I intentionally deployed a bigger size compared to this is the narrowest point.
Okay.
I have to dilate more.
All right.
It's corresponding the angiographic appearance. This is the one of the way to avoid some edge dissection. And the remaining part is the second diagonal wires coming. This is another narrowing in the proximal part. Okay. 3.0. 이건가? 네. 3.5.
NC balloon 35.
Yes.
All right.
Dr. Hong,
yes.
As you showed, the distal aspect of the stent is in some mild plaque, right?
Right.
If you had maybe IVUS a little bit more distal and you found a more area where it's a landing zone which is a little bit less diseased, would you tend to go a little bit more longer with disease-free area, or it's okay to put it in mild plaque? What are your thoughts about that?
Relatively amount of the plaque, I'd like to just let it alone. What I mean is that the extension of the stent length, it means that the risk of the ischemic complication, we need the duration of the dual plate therapy is proportionally increased. So, maybe there is some the moderate degree of the plaque and just let it alone and follow. And at the time of the disease was clearly progressed. At that time, I will deploy the additional another stent at that time, not here, not this time. So try to that is personally the lesson from the physiologic finding. Okay, there is some moderate plaque, so we have to do the stent based on the IVUS finding. No, I don't think so. In the long time ago, in the past, we did, but physiologic study show that moderate degree of stenosis, just let it alone and follow. Nominal만.
Well, nominal.
You, Michael, you worry about stent placement, landing zone, right? Normal. Basically, normal to normal, right? Is
Ideally,
correct.
yes.
Ideally, right?
Okay.
However, in diffuse disease,
there's no landing zone that you could put a nice area.
Very old data. We have some data, and so at least the plaque burden less than 50%. Old data. However, that is our own one. And if the plaque is concentric one, actually no, effect, no influence in terms of restenosis, something like that. And so
if there's no edge dissection.
yes, it is. So plaque burden less than 50%, something like that.
Even though I did the post dilation and 3.5 in the distal, As you see on the fluoroscope image, there is some mild indentation of the stent. It makes I'd like to just let it alone, even though actually I dilate is at the 3-point iris. I did it. It's some resistance. So if I do the more, maybe there is a risk of some perforation. So I don't like the perforation in the live demonstration.
Dr. Hong, your NC balloon was an 8 millimeter or 12 millimeter?
얼마지? 에이샤 아니면? 에이샤 아니 더 길어 보이던데 길이가. 3.5 맞습니다. 8.
Right, and you do
I
that.
don't know what it is, but they told me that it's 8.
Just using. Do you see any difference or any advantage by using a shorter NC balloon to get more of a focal force effect?
Yes, shorter is the more stronger.
Like more of a PSI, point per square inch.
Yes. 잠깐 stop. Could you show us? Okay, this is the IFC image run after the post dilation. This is a distal reference. This is a landing zone of the distal stent.
At least, stent diameter is more than 2.5, something, right?
More than a 2.5. Almost
diameter,
2.7.
and so area concern is at least 5 millimeter, scale is quite enough. I think it's quite enough, right?
Right.
And so proximal part is bigger than that. Two, 3 or something, right? Diameter.
Yes. Transition is excellent. So it's time to the final angel for to evaluation of the status of the diagonal branch flow. If there is something happen in the diagonal side branch vessel, I will try to fix it.
Right.
Suppose that the diagonal branch were to get compromised, would you just use a single balloon to dilate the diag, or would you do kissing balloons to make sure you don't distort?
Single balloon.
So you're not concerned about distortion of the stent?
Just the patency, right? Make a patency.
Yes, small size of it. And if I do a stent,
Michael,
I personally
just guess.
coating balloon.
What about the side branches? Compromise. If you take a picture,
I think you're going to be fine. I think you're going to be fine.
Right. Good.
Okay, let's check it. Ready?
No problem. Right. Perfect. I like it.
그래요.
Can I ask you a favor? Can you do an LEO cranial view, please? I want to look at the diag more.
There's many.
More.
Morphology, angiographic morphology is not too.
Well, it was fine, but I just want to see.
All right.
좀 하나 더 풀어. 아니죠?
I think it's perfect, right?
So, I'd like to emphasize that, please, I know that POD is very useful, but imaging is more important than the POD.
Right.
That is my conclusion.
All right. So in terms of a minimal stent area concern, I think it's quite enough. However, if the case is mine, so I do a little bit, a bigger non-compliant balloon for 5 high pressure inflation, 3.6, 3.7 something. All right. However, totally I agree with your concern, and procedure itself. Any comment on that, Michael? All right, just on time, Dr. Hong. Really thank you for nice case presentation as usual. So really thank you for supporting us, right? Okay, great. So last three, Dr. Ahn. Dr. Ahn, can you hear me? All right, so would you Show us the final angio.
Yeah, this is a spider of the final angio.
Ooh, perfect.
Yeah, the left main stent is big. I implanted another stent to the medial AD.
Epicranial view, please.
This is it.
Perfect. So you didn't do FFR again? All right. All right. It's great. Great, nice cases, right? Thank you for all right presentation. Okay.
Okay, great. All right. Our next speaker, obviously, Dr. Park is course chairman. The lecture will be Left Main PCI, Make It Simple. Dr. Park.
I hope you all enjoy these programs as live cases. And so finally, I want to say make it simple, right? Main PCIs, you've seen many cases. Anyway, current status of the main PCI is low syntax, intermediate syntax. Docile is 1A, 2A, even almost same in ACC-AH guideline concerns, depending on a high anatomic complexity concern. Suitable candidate bypass surgery, however, not suitable candidate for bypass surgery. PCI would be class 2A, simple, or I would say more complex region, we can do a supportive PCI for that. Main disease, I would really say that is not surgical disease anymore, right? So practical guideline, extensive non-main, coronary artery disease, cerebral disease subset, high syntax score, just I've shown the slide, from the Excel studies, more than 45, concomitant cerebral disease present bypass surgery may be strongly preferred. Multiple comorbidity status, present PCI may be preferred. Look at that. High syntax score here is 65% cerebral disease combined, concomitant cerebral disease. If you look at technical point of view, anyway, disease main only disease. Actually, all issues of a high syntax score mainly related with the concomitant multivessel disease. And so if you solve the multivessel epicardial artery PCI concern, it's quite easy, to approach the main itself. It's not related with the main disease, main PCI itself. If you look at only the main disease, big vessel, proximal disease, proximal vessel, so short lesion length is required, really good target for PCI. So I would say main PCI, main disease, you have to concern about the concomitant cerebral disease. However, it's very good target for angioplasty. We have to consider contemporary physiology, image supported, absolutely ischemia guided PCI, and so FFR guided decision making, IVX guided optimization. I would focus on that one. Ostial shaft main disease, to treat or not treat concern. Look at this, very interesting cases. 70% tight stenosis. However, 0.86 negative FFR, significant stenosis and negative FFR. Some mismatch, minimal lumen area is 4.9 millimeter. We have some cutoff value 4.5, ostial shaft region, concern. Look at this, not too much disease. However, 0.72. Insignificant stenosis, very strong positive FFR, minimal lumen area 4.0 millimeter square. Another cases, almost 30%, not too much significant, and 0.7 positive FFR. If you look at, inside, there are some plaque ruptures in, So mismatches in intermediate ostial shaft lesion subset, 37%, and 26% reverse mismatch, 11 mismatches. And so I would briefly, talk about FFR versus IBS MRA concern. This is old data. Just this one, they matched with the FFR 0.75 with downstream disease cutoff value 6 millimeter square. So that is our data. Ostial shaft regions matched with the 0.8, the minimum lumen area 4.5 millimeter square. So I would just implement osteal-shaft lesion by IBIS finding less than 4.5 millimeter scale, it's absolutely positive ischemia, positive FFR. If there are some downstream disease, more than 6 millimeter scale, negative FFR. Between the two, we have to consider FFR, definitely. How to treat concern? Very easy, you know, the osteal main disease, just do it, just send it. It takes 5 minutes, you know, 1A class, and all right, angiographically, 2 years, perfect. Osteal shaft main, isolated main disease is not surgical disease anymore, right? Bifurcation main disease, how to treat concerns, 1 stent, single stent crossover, 2 stent, true bifurcation, big vessel, Medina class 111, so 011, any true bifurcation, larger circumflex more than 2.5, we're going to do the upfront 2 stent. Almost by IBIS findings, main disease, bifurcation disease is not isolated, extended, you know, LAD to circumflex, I would say, kind of functionally single unit of disease, and still functional evaluations may work to, you know, treat or not treat decision-making concern, right? There is Hamilos data, almost old one, 29%. If the main disease had a downstream disease, 29% mismatches still, 23% reverse mismatch, right? Bifurcation PCI, how to treat concern, region-specific provisional 1 stent and upfront 2 stent. I would say IBIS guided region-specific approach absolutely, you know, important. So I was finding, I was insight, osteal lesion assessment and the reference special alignment, usually big, you know, rather than angiographic evaluation, lesion length, intermediate lesion evaluation, plaque characterization, procedure optimization. This is all data, however clear, IBIS guidance saves lives. So this is cases, true main bifurcation. However, if you look at the IBIS finding, circumflex ostium almost free of disease by, you know, angiographic findings, some mismatches. We did just a stent crossover and high pressure inflation, etc., etc. Look at this. Very almost perfect, you know, angiographic result. The circumflex ostial part is good. And another case is LAD, all right, positive FFR, circumflex is negative FFR, minimal luminaire, and main is 5.3 millimeter scales. And so we did just the stent crossover for particular these cases. And there are some hesinies on the circumflex ostial part. All right, we have to realize many mismatches between the morphologic circumflex jailing and FFR. In top cases, in almost all cases, negative FFR. Only 7%, more than 90% of compromised circumflex ostium negative FFR. If we do not touch, may increase TLR, no difference of what, you know, hard endpoint. And I would say, don't touch. Even in the, you know, compromised circumflex, we can avoid unnecessary procedure. Upfront 2 stent, the typical, you know, true bifurcation disease, circumflex ostium, some disease, lots of disease. We did mini crushing. We like that one. Circumflex stent first, and then LAD stent, final kissing balloon inflation. You can get good final angiographic findings. Minimal stent area is good enough, and we published our, you know, minimal stent areas after the 2 stent 5, 6, 7, 8. According to the 9 months response rate, recent published data, 5 years base rate, according to this, it'll bigger, you know, cutoff value stent area concern. So whatever you used, any 2 stent technique, the only important predictor for good clinical outcome is a post-stenting minimal stent area. That is based on our data. So main PCIs, you know, make it simple. So, evolving concept, imaging, and physiology guided PCI can improve clinical outcome. And upfront 2 stent for true bifurcation and main disease to be safe and good. Thank you.
Great. Thank you so much. Our next speaker is Kefei Dou from China. Left main PCI, impact of residual ischemia on cardiovascular mortality.
Good morning. It's a great honor to be here to present our work and nothing to disclose. And as we know, left main lesion has long been recognized as a crucial anatomy subset for CD associated with the high mortality. Meta-analysis demonstrated no significant difference between PCI and the CABG with respect to rates of 5-year mortality. Left main PCI frequently involves distal bifurcation, usually associated with the complex procedures and inferior outcomes. And after left main crossover stenting, circumflex residual ischemia was nearly 16% and associated with poor prognosis. And the wire-based physiology is underused due to several reasons. Our study is to determine the rate and the prognostic implication of post-PCI physiological residual ischemia according to Myeong-Ki after left main bifurcation PCI. Myeong-Ki is an AI-powered Murray bifurcation fractal law-based QFR. It can support single angiographic wheel computation, support analysis of bifurcation lesions, and we can use it to analyze very fast and around 1 minute. And accuracy is very high, around 93%. Our study is the post-hoc blended analysis from a post-prospective cohort, which consecutively enrolled patients with unprotected left main PCI in Fuai Hospital from 2014 to 2016. The primary outcome is 3-year cardiovascular death. The major secondary outcome is bifurcation-oriented composite endpoint. We checked the 2D Myeong-Ki assessment were separated in main vessel, left main to LAD, and side branch to circumflex based on different single angiographic views. Physiological significant residual ischemia defined by post-PCI Myeong-Ki values less than 0.8. We enrolled 1,300 patients with left main PCI from 2014 to 2016 and excluded 150 patient with AMI or unanalyzable QRF vessel. Finally, 1,170 patients were enrolled. And all the patients, we did follow up more than 98%. We found post-PCI residual ischemia was detected in 13.2% patients after left main PCI, with circumflex ischemia only 10%, LD ischemia 2.7%, and both side ischemia 0.5%. As compared to no residual ischemia group, residual ischemia group have more diabetes, more hyperlipidemia, lower left ventricular ejection, and higher anatomic syntax score. When we look at the key procedural characteristics, residual ischemia group have more provisional stenting technique and less final kissing balloon technique, and higher residual syntax score. After logistic analysis, we found 8 predictors of residual ischemia, including left ventricular ejection fraction, true left bifurcation, side branch diameter, syntax score, and pre-PCI circumflex Myeong-Ki, provisional stenting technique, side branch diameter stenosis, and the residual syntax score. When we look at the major endpoint, we can see residual ischemia group has very high, significantly high cardiovascular death. It's 5.4% versus 1.3%. And the hazard ratio is after adjusted is 3.2. A similar thing happened in BOC. It's 17.8% versus 5.8%. We also found residual ischemia regardless of LAD or circumflex was associated with worse outcomes, especially even only circumflex have a residual ischemia has a very high, significant higher cardiovascular mortality. We can see here its cardiovascular mortality is 6.2% versus 1.3% as compared to no ischemia subset. And in addition, clinical outcomes were inversely and continuously associated with post-PCI mu-QFR. Per 0.1 decrease in post-PCI mu-QFR value, the risk of 3-year cardiovascular death and the BOC increased 27% and 29% respectively. And when using post-PCI mu-QFR and the diameter stenosis % for physiological or anatomical significance, mismatched results were found in 15.1%. And the physiological assessment showed the superior prognostic value for 3-year clinical outcomes. Here I raised some discussion point why post-PCI residual ischemia is related to 3-year cardiovascular mortality, but not only related to composite endpoint. How to optimize the interventions based on post-PCI physiological assessments. Finally, I would like to make a brief summary. After angiographically successful left main bifurcation PCI, residual ischemia assessed by mu-QFR was identified in 13.2% of patients and was associated with higher risk of 3-year cardiovascular death. Adopting the strategy of routine post-PCI physiology-based assessment when treating left main bifurcation lesions is necessary, even when PCI appears anatomically satisfactory. Thank you for your attention.
Thank you. Great, great, talk, and really, Michael, you got some ideas?
This is fantastic. I mean, we saw 3 great cases, a lot of decision making, but I think the thing to emphasize most is just imaging. We had complex bifurcation lesions which all required just single stent crossover just by assessing the side branch. So if you're going to do left main, please do imaging.
Okay, Dr. Dou, come on the stage. So we have some. Okay, actually your main PCI procedures, what % of PCI are related with IBIS guided, IBIS evaluations?
You mean all the PCI or just for left main?
You do.
Just for left main, we're around, in my team, 100%.
IBIS guided,
but
right?
in this study, it's 50%.
50%?
Yeah, 50%.
IBIS guided. So what I have a concern about, finally, the residual, ischemia related with the natural disease itself. In some cases, for example, the diffuse disease, we want to fix some part of a proximal. They are residual ischemia, right? However, we cannot fix up that, right? So simply, residual ischemia related with a hard endpoint cardiovascular death is good if there is a phenomenon, right? However, if you look at the inside, actually residual ischemia in some part of, I would ask that, all right, the next stage of your study maybe, right? If you got some residual ischemia, how many cases is correctable or is just not correctable? That is.
Actually, we are doing some work. We use the virtual QFR. It can predict the QFR value after PCI. But if you calculate the virtual QFR is bad, sometimes we will reject patient transfer to cabbage.
Dr. Park, when you do left main and your team does left main, is there a benefit with IVUS or OCT, or does it matter?
Right. There is our data, Octibus. Right. So for the main disease concerns, it'll be prefer IVUS. The reason why is big vessels, osteopathy, a little bit difficult to evaluate by OCT, right?
And less contrast use.
Great. All right. Thank you. Just on time. So we want to move second live cases session. And 10:15. All right. So we're gonna. Okay. I'm gonna fix the finish.